We will do that now. Arrived at the morphology of reversible cell injury from last week. Assalamu alaikum, everybody. Sorry about being late. I had a very long day yesterday. This week, unfortunately for you, it coincided with the deadline of the NRMP, that's a residency program application in the US, and also the deadline for the NCAA accreditation for your college. So both of them happen to be in the same week, and honestly, I am swamped with work. Anyways, let's talk about morphology of reversible cell injury. This is where we arrived last time. If you recall, what we have said last time is that as a result of the failure of the pumps resulting from the fact that ATP is no longer there, those pumps are going now to allow certain electrolytes in the cell and allow water in the cell as well. So you will see that sodium, as a result of the failure of the NAK pump, is going to be wheeled in. So with sodium, water will follow. As a result of that, the cell will swell. And that's exactly what you're going to see when you look in a light microscope. If you look in a light microscope, you will see that the cell has increased in size, what you call hydropic changes. Not only that, actually, if you look at the membrane of the cell, you will see that this membrane of the cell has given way, meaning it started actually to develop a certain form of a projection known as blebs from the increased water tension inside the cell. If you look at all the organelles of the cell, you will see that it has swollen because water has come into it and started to actually lose its normal structure, what you call dissociate from its normal surrounding and structure. So that's actually one of the first signs that you're going to be seeing with regard to reversible cell injury. Right, now fatty change, I did receive a couple of questions about fatty change. Why do you see it? Now, if the cell is actually entrusted with the metabolism of fat, if it does not find actually the protein carrier, those fat droplets are going to stick in the cell. And as a result of that, you will see what is known as fatty change. Furthermore, the proteins are also carriers of fat in the blood. If you stop actually seeing protein synthesis, the same exact thing will happen, because you will see, in this case, that there is no longer carriers for fat, and the fat is going to start to get deposited in the cell. Where do you see it usually? Usually seen in the kidney, heart, or liver. So of course, a picture is worth 1,000 words. This is the normal cell right here. This is what happened when the water starts to come in as a result of the failure of the NAK pump. So you will start to see that all organelles have started to lose its normal structure, what we call dissociate, and actually lose its relationship to its surroundings. Not only that, you will start to see also chromatin clumping. And we have talked about why chromatin clumping come to happen. Chromatin clumping happened because ATP is no longer there to sustain the function of certain enzymes. That's number one. Number two is that the cell, when it realized that it cannot actually go through the oxidative phosphorylation to get its ATP, it will start to result to breaking down the glucose, right? We talked about this, in order to actually obtain a very limited number of ATP, that's 2 ATP per glucose molecule, in what is known as anaerobic glycolysis. Now, one of the byproducts of anaerobic glycolysis will be the production of lactic acid. So lactic acid is going actually to decrease the acidity, to decrease the pH of the cell, making the cell acidic. And as a result of that, the pH will no longer be optimal for the function of certain enzymes. One of those enzymes is entrusted in the maintenance of the chromatin. And as a result of that, you will see that the chromatin will start to become disrupted. But that's a very mild, actually, form of disruption. If it goes anything beyond that, then you have to start to think about irreversible cell injury. So this is the first and the only sign of nuclear disruption that is seen in reversible cell injury. That is nuclear chromatin. That's an important thing to remember. Now, if you remove actually the pressure, if you remove the hypoxia, for example, or if you remove the anything that is making the life of the cell harder, you will see that the cell could go back to normal. Why? Because none of the irreversible changes happen. Those irreversible changes are going to be in three locations. The first one is in the mitochondrial membrane. The second one are in the membranes of the cell in general. And the third one, like I mentioned to you before, it is in the nuclear chromatin. If changes in those systems did not happen yet, or very light kind of changes happen in them, the very early stages of disruption in those structures, the cell could go back to normal when you remove the stressor, the hypoxia, and so on and so forth. And eventually we'll go back to cell recovery completely. All right, here is a beautiful picture showing you, what we have been talking about here. So this is a kidney that is affected by actually hypoxia. So as a result of the failure of the pump, you will start to see that some of the cells have increased in size. Compare the size of these cells, of these tubular cells, to these tubular cells right here. This cell here is almost like 6, 7, 8 times the size of this, correct? Not only that, you will start to see the organelles, even at this power, the contents of the cell have become actually disrupted. Why? Because there's so much water influx. It spreads it about, through the cell. Now, if you look at these cells as well, you will start to see that it is not just reversible. If you look, you will start to see some of these cells, probably not all of them, but some of them have lost their nucleus. And the reason for this is that probably the injury has been going on for a while, that some of the cells have died, as simple as that. Right? Another way actually to figure out that, where is the nucleus is that you're cutting actually this tubule, in a tangential cut. So when you look actually at the nucleus may not have actually been in that cut, meaning hidden away, because it's a 3D structure. But some of the cells definitely have gone, dead. Why? Because you no longer see the nucleus. So remember that, no nucleus meaning cell death. One very important sign of cell death. Now, compared to this normal epithelium here, what do you see? You will see that those tubules are smaller, right? Tighter. You will see that, the nuclei are all apparent, as you can see here. Of course, the fact that the cell is small makes it more likely than when you cut, you're going to be seeing the nucleus. Here, as a result of the increased size of the cell, you cut, maybe the nucleus is at one end of the cell, the 3D structure of the cell, so you will not be able to see it. All right, but some of the cells definitely lost their nuclei and died. Here's another great example, actually, of what you see with reversible and irreversible cell change. This is resulting from coronary ischemia. So if you recall, I did mention to you before that the coronaries cruise on the surface of the heart, and they send actually perforating branches into the myocardium to supply the myocardium with blood. If it happens that actually there is an obstruction at the site of origin of one of those branches, or if, the coronaries itself, what you're going to find is that, depending on the closeness to the site of origin, let's say actually that this is where the most superficial part of the myocardium is. So this is where the coronary, artery is actually cruising, or close by. So what's going to happen is that the most near area is still receiving some of this blood. Why? Because the obstruction obviously did not really completely close that vessel, that is, affected by atherosclerosis. So as a result of that, the nearest area is still receiving some blood supply. And as a result of that, you see it viable. At least in light microscopy, you don't see any changes in this area. Now, in the area distal to it, you're going to see that some of these cells actually have undergone a reversible cell injury. Why? Because they have gone, larger in size. So all these vacuoles that you see within the cell, what is known as vacuolar change or hydropic change, is most likely going to be water, resulting from the failure of the pumps of these cells, because it's no longer receiving the oxygen, and as a result of that, the ATP is taking a dive, and as a result of that, those pumps are failing and allowing the sodium to come in with the water. Now, some of these cells, as you can see, it's not really one condition for all the cells. Some of the cells managed actually to stay alive. Now, if you compare that to this area, which is the most distal away from the coronary artery, what you're going to find increased redness of this area, right? It's very red. The red color is actually the color of death. I know red is a favorite color for a lot of people. Yes, sir.
They are asking you want the pointer so they can.
The pointer, please. Thank you.
Straight the Anwar.
No problem. Thanks a lot. Yeah, good. But it won't appear with red also. This is fine. All right. So what you find here is that this is the third area, area number 3, is the most distal away from the the coronary origin, if you will, from the coronary branch, and as a result of that, it's going to experience more actually ischemia than area 2 or area 1. And there is a couple of reasons for that. One of them is going to be the caliber. As the vessel cruises down, it's getting smaller in caliber, right? This is number 1. Number 2 is that this is myocardium. So as a result of the tension of the myocardium itself, especially that it no longer actually have the same amount of blood that is seen in normal condition, that's going to result in its collapse as it is. So it will collapse as it tapers down actually towards the inner side of the myocardium. And as a result of that, you will see that this area has completely died. There is no coming back from this. So a reddish color of the cytoplasm is actually the color of death. We'll talk about that in the next lecture. Then if you look at the nuclei here, you will see that probably you see one nuclei right here or one nucleus right here, but the rest of the nuclei are completely gone, which is another sign, another what you call solid sign of death. All right, so normal, area 1, reversible change in area 2, irreversible change and cell death in area 3. Here's another example, in this case of reversible cell injury, in this case of the liver. Here what we are finding, we're finding actually the lipid that is no longer finding the its long companion, if you will, the proteins, to be wheeled around, to be carried around. As a result of that, it will be there in the liver cells, in the hepatocytes, appearing in what is known as fatty change. So all these vacuoles are what you call fat vacuoles. One question that should come to mind is how would you be able to differentiate between water vacuoles and fat vacuoles? If it happens to come to your mind, one way to tell the difference between the two is actually through the use of special stains, such as fat stains known as oil red O. So in this case, the fat will take it and it will be red. The water will not, because it does not have actually fat in it, and it will not take the red color. All right, so now the structural changes of reversible cell injury. So this is a diagram to show you what happened at the level of the ultrastructure, at the level, or using an electron microscope. When you use an electron microscope, you're going to be seeing changes that you will not be able to see in the light microscope, because the magnification will be in the tens of thousands, almost 100,000 folds increase in size. So what you're going to be seeing here, I think a picture will tell you everything. So this is the normal cell. Everything is happy and dandy here. Compare that to reversible cell injury, where the plasma membrane will start to bleb out, resulting in formation of these blebs. Again, the cellular structure will start to dissociate, resulting in the appearance, that you see here with regard to the RER, and with the result to everything else actually within the cell. You look at the nucleus, water has gone into the nucleus. You look at the mitochondria, the same thing. So water has actually gone into all cellular organelles, resulting in these kind of presentation. All right. And of course, the nuclear clumping that we have talked about. in the previous slides. All right, so what do you see with irreversible cell change? Now, the start of the action here is going to be nuclear changes. So what you're going to be finding, you're going to find actually everything else that we have seen in the previous reversible cell injury changes, but it will be attenuated. So there is truly, there is plasma membrane disruption, but it will be severe enough to result actually in the wholesale influx of things that don't belong to the cell, and also the release of certain contents of the cell in the nearby surroundings. So anything that you have seen in the reversible cell injury will be there and will be added on. But the one that is going to be distinctive for this phase is going to be the nuclear changes. What are the nuclear changes that we are talking about? So that's going to be three, really. One of them is the pyknosis. That's when the nucleus becomes smaller and becomes rounder and denser. And Arabic words for it is kuwirat. Have you guys heard it before? Yeah. Right. So it becomes smaller, denser, and rounder. That's going to be followed by actually, simply fragmentation of this nucleus. Fragmentation and, destruction of this nucleus. That's going to be followed eventually by karyolysis, when the nuclear fragments will simply disappear altogether. They will no longer be there. Here's a great picture actually showing you these changes, not this, the next one. So here, where you start to see the nucleus have gone smaller and denser in shape and size. Here, where it starts to fragment into smaller fragments, eventually disappearing in the process of karyolysis. And here's a great picture showing you that. So in this case, you will see first the nuclear pyknosis. Compare the size of this nucleus to the size of nearby nuclei, and you will see what I'm talking about. It's much smaller, much denser, much rounder than those nuclei. Then it's going actually to fragment eventually. As you can see, it will result in multiple nuclear fragments in the process of karyorexis. And then eventually it will simply completely disappear. So you will start to see shadow of where it was, but the cell will simply be void of any kind of nucleus or nuclear fragments. Here's a great example of that. Look at this cell. No nuclear fragments whatsoever, no nucleus whatsoever. Again, how did this happen? The nucleus has gone through the process of irreversible cell injury because there was no, for example, how does irreversible cell injury happen? We did talk about this before. Either it happens right off the bat by a special type of injury to the cell. For example, free radical injury. There is no recovery from a free radical injury to the cell. If the injury is overwhelming, the cell simply will die off. Or actually, if it happens from an injury to the cell that the cell could take, but it was in extreme amounts. Or an injury that the cell could take, but it lasted for longer duration. We did talk about how come the cell will go through an irreversible cell injury and cell death, right? In the prior lectures. All right, so again, the start of the process will be right here, the nuclear changes. This is going to be very distinctive. This is even though it is really very advanced, but this is going to be very distinctive to the irreversible cell injury. And the one that is going definitely to give out reversible versus irreversible, because you see everything else in reversible cell injury, but at a much lighter, at a much milder kind of way. So you will see cell membrane damage. You see them in both, right? You see rupture of the lysosome. More or less there is dissociation. There is dissociation of the polysomes, and there is probably slightly, decreased integrity of all the membranes, including the lysosome. Lysis of the endoplasmic reticulum, mitochondrial swelling, larger densities in the mitochondria. That's also reserved for irreversible cell injury. And nuclear changes, like I told you, will be the one that is going to give, the clue that what you are having is irreversible rather than reversible cell injury. Here's an example of that, and you can see actually that the changes that were seen in the reversible cell injury now have definitely increased in severity, right? You look at the membranes, and you will see that the membranes is much more degenerated than what you have seen in reversible cell injury. You look at the nuclear chromatin, and the nuclear chromatin is no longer actually becoming clumped only. It's becoming, in addition to being clumped in the phase before that, it will start actually to condense into a much smaller, structure, much rounder structure, as you can see here, in the form of a pyknotic nucleus. And then, you will see also the lysis of the endoplasmic reticulum. You will start to see disruption of all different types of cell membranes, the plasma membrane, the lysosomal membrane, the mitochondrial membrane. You will start to see the larger densities, that are found in irreversible cell injury in the mitochondria. All right. Now, that we have finished reversible and irreversible cell injury, we're going to be talking a little bit about other examples of cell injury. So we started with hypoxia, right? That's number one. Number two will be free radical injury. Again, if you're actually going to tally the most common cause of cell injury, it's going to be free radical injury. That is going to be really the underlying theme of pretty much everything. Now, you don't really see it as such because there is, it's not going to be listed as such. So if a patient died as a result of, ischemia resulting actually in hypoxia of the myocardial cells and death of those cells, you're not going to list that as actually free radical injury, even though free radical injury played a great role in that death. If someone died as a result of a Tylenol overdose, again, you're going to be, writing it as such, but you're not going to say that this is resulting from free radical injury, even though free radical injury has a huge role actually in the death of that patient, the death of the cells of the liver, and eventually the death of that patient. So it is really what you call the elephant in the room. You don't really, that it is the underlying etiology, but you're not really counting it. You're not really counting it in. Now, how does that come to happen? Where are these free radicals being formed? We already talked about what are the free radicals, right? The free radicals are those compounds that are missing an electron, on its outer orbit. So if you think about it, its mission in life is going to be actually to bring up the number of the electron on its outer orbit to a double number, to a 2, for example. So in this case, it's going to try to steal this electron from anything and everything that it that it meets in its life cycle, whether it is actually another compound or whether it is another component of the cell. And in the cell, it has affinity to two sites. The first one are the plasma membrane, and the second one is going to be the nuclear chromatin. So it shows actually two structures in the cell that injury to those structures is going to result in irreversible cell injury. This is why with a free radical injury, usually if it's not incredibly mild, very tiny amounts of those free radicals, the cell is going to die as a result of that exposure. So how does it come to happen? How does it get formed? One way for it to be formed actually is going to be through ionized radiation. That could happen, either intentionally in the form of a radiation treatment. You have the patient has a tumor. You actually, put, the radiation beam on that tumor. The tissue surrounding, the tumor is going to receive this radiation beam, and it's going to split water. The radiation beam will split water in those cells in and around the tumor, resulting in the formation of the hydroxyl group, the hydroxyl free radicals. Now, I told you also that with damaged mitochondria, let's say that there is hypoxia to the cell, mild hypoxia. It may actually sound as it's a mild or a minor change, but the mitochondria itself will cease to function. The mitochondria is going to start to actually have very intricate problems in its function. Why? Because the membrane of the mitochondria is going to be affected. And on the inner side of the membrane, that's where the oxidative phosphorylation happens. So as a result of that, there will be no full reduction of the molecular oxygen towards the production of H2O and the production of the ATP molecules that you see with oxidative phosphorylation. So the result of that is going to be that this process will stop in its track. And when it stops in its track, that's going to result in the formation of the superoxide free radical. So partial reduction of the molecular oxygen that results from the disruption happening as a result of hypoxia, for example, will result in the production of superoxide free radicals. If you give oxygen, on the other hand, so you're giving really, if you're giving, oxygen itself, especially if you give it to someone who is an infant, and especially premature infants, you will see that this oxygen, high content of oxygen, may result actually in the formation of free radicals. In this case, all three, major free radicals, which are the hydroxide, the superoxide, and the hydrogen peroxide. Medications is a huge number. Probably that's going to be the most common cause of free radical formation. When they get metabolized by the liver, a free radical may actually result from this, metabolism. Example of that, what you see with, acetaminophen, with Panadol, Tylenol, many names for it, that is going to actually start wreaking havoc. So this free radical will form if the patient is overdosing on this medication. The end result will be that these free radicals are going to wreak havoc on the liver cells, injuring the liver cells, killing the liver cells. As a result of that, this patient may die as a result of liver necrosis. Where do you see, the most common site within the liver, where, medications in general and all types of toxins, get reduced or get dealt with? If you remember the liver, structure, it is 3 areas, right? Or 3 zones, if you will, zone 1, 2, and 3. Zone 1 is the area in the periportal, the portal and the periportal triad area. Zone 2 is the area in between. Zone 3 is the pericentral vein area. Where is the area that is mostly rich with the enzyme system that is going to reduce toxins and medications and so on and so forth? And it is the area, sorry? Zone 3. It is zone 3 for sure. Zone 3, the pericentral region. So this is why, for example, if you do an autopsy on a patient who overdosed on acetaminophen and died, you will look actually mostly, the first thing that the pathologist will do is look at the areas of zone 3. And they will see that those areas of zone 3, the area around the central veins, are going to be actually necrosed as a result of this, cell injury that happened from the free radicals. Cigarette smoking, we did talk about this pollution with the nitrogen dioxide, and that is present in car exhaust that may result actually in the formation of free radicals. Metals, such as what you see, in patients who receive blood transfusion, for example. Let's say someone has thalassemia and is dependent on blood transfusion for life. As a result of the increased, load on the system of iron, iron is going to actually go through 2 cycles of reduction, of oxidation and actually reduction in the phenol reduction that will result in the formation of 2 free radicals that will wreak havoc on multiple organs in the body, including the liver, where it's going to result in eventually in the later stage in liver fibrosis and liver cirrhosis, in the pancreas, where it's going to result in the destruction, especially of the islets of Langerhans. That's going to result in diabetes. You will see it in many organs in the body that may result actually in death of that patient. You see it also in patients. So you may see it with patients who are dependent on transfusion. You may see it also in patients who most likely actually to be seen in patients with hemochromatosis. That's a genetic disease where there is much more overload of iron than what you see, for example, in transfusion patients. Even the atherosclerosis, the belated atherosclerosis, what you're going to find is that even atherosclerosis, the underlying etiology really of its development is going to be free radical injury. So in this case, you will see that this lipids that has overwhelmed the transportation system that it uses. Lipids use actually protein carriers to be wheeled around in the blood. So what happened if this lipid, if this LDL, for example, cholesterol, has increased to the point that there are no longer actually protein carriers for it, the apolipoproteins, that we know about that carries it in the blood. The result of that is going to be that this LDL cholesterol will start to get deposited into the intima of the arteries. And when it gets deposited into the intima of the arteries, and as a result of its interaction with the macrophages that are going to be there actually as a transient kind of inflammatory infiltrate, the result of that will be actually producing oxidized cholesterol crystals that are going to wreak havoc in and around, the area where it gets deposited, resulting in cell fibrosis. And the production of what is known as a fibrous cap that is going to be the bedrock on which the atherosclerotic plaque will happen. How is that happening? How does a fibrous cap, let's say that a fibrous cap has formed within the wall of the artery, so it has lifted the wall of the artery slightly. That's actually why you call it a cap, because it looks like a hat, a cap, right? And it is fibrous. So how does the fibrous cap, form actually an atherosclerotic plaque, or why does it form an atherosclerotic plaque? Any idea? You're going to be seeing this in this block in hemodynamics. So in this case, the laminar flow has become disrupted, right? You know what laminar flow is, right? Should have taken it in physiology. Laminar flow, where you see that the cellular content of the blood are going to be in the middle, right? Whereas the plasma is going to be on the acellular contents will be on the sides of that, core, if you will. And when there is actually, the laminar flow will get disrupted in one of two ways. One of them in stenotic area, this is one, and two, when the circulation slows down, right? So in the microcirculation, that's why this fibrous cap will be the starting point of the atherosclerotic plaque. All right, so what are the free radicals that we know about? Starting with the superoxide, this is the one that is known actually the most common probably, if you want to make a count of what is more common. By the way, there are a lot of actually free radicals. The one we are mentioning here are just the tip of the iceberg. This is the most common and the most famous, I think, way to put it, to keep in mind. And each one of those free radicals have actually a system in the cell to deal with it. Now, this system can deal with these free radicals until a certain point. Usually, this is really a very low threshold point, meaning any kind of excess is going to result simply of overwhelming that mechanism and killing the cell. And it is usually either specific to that free radical, such as what you see with the dismutase, or actually it's going to be what you call one size fits all. That's a system that is going to be taken care of by one system that's going to take care of many type of free radicals. All right, so one very important, as I mentioned to you, probably the right way to put it will be to put the drugs and the chemicals as the most common. That's usually as a result of the worldwide use, very high use of drugs and chemicals. That's going to be number one, and that's actually what happened when you see it being metabolized in the cytochrome system, the cytochrome P450 in the liver, in the area that we talked about, which is zone 3. All right, and how the free radical come to happen. Again, it is going to steal this electron from anything that it passes its way, and in the process of doing so, what does it do when it does that? So it is a free radical. It needs to bring up the number of the electrons on its outer orbit to 2, steal it from somewhere else. What happens to the other cellular components or to the other compound? It itself becomes a free radical. So it's a vicious cycle, it's never-ending cycle. So one of the best way to do it is to come about and give actually electron to that compound, right? That's exactly what vitamins do. Vitamins donate one of their electrons to the free radical to simply, put it to rest. All right, so how does it happen? How does injury happen in the free radical injury? In a couple of ways. The most solid, the most confirmed, the most known is actually lesions in the DNA. It compounds in the DNA and simply, destroy it. Or actually, it will result in increased lipid peroxidation and breakdown. And when it does that at the level of the cellular membranes. By doing this, It makes these membranes much more porous, and that's going to result in irreversible cell injury. And finally, oxidative modification of the proteins resulting in its fragmentation and degradation. Right, so now the neutralization systems that I just mentioned to you, so either it's going to be specific or it's going to be one size fits all. So in this case, you will see that the glutathione peroxidase, I'm sorry, is going to be, taking care of the hydrogen peroxide, the hydroxyl group, and the acetaminophen free radicals. Catalase will take care of the hydrogen peroxide. Vitamins as antioxidants. How does the vitamins do it? In one of two ways. One of them is going to be to donate, one of its electron to the other, to the free radical and putting it to rest as a result of that. The other way is simply to prevent lipid peroxidation from happening, and by doing this, it will keep the membranes of the cell intact. Another example of free radical cell injuries, that we have mentioned is going to be the acetaminophen. We did talk about this. Ischemia-Reperfusion Injury is a form of free radicals. There is actually a couple of slides. We're going to talk about it in much more detail. And then there is the retinopathy of prematurity that may result in blindness as a result of treatment of high contents of oxygen to those premature infants, preterm infants. Right, so iron overload disorders, I did mention this to you. That's with hemochromatosis, the genetic, disease, hemochromatosis, and the hemosidrosis, which is most likely going to be transfusion-related disease. There is also not just iron, but any kind of really heavy metal, for example, copper overload. Of course, that's going to result in, with iron, it's not going to happen like overnight, because that accumulation is going to take a long time to happen. And the more severe the disease, the more likely that the presentation will happen at a young age. So with the genetic disease, you're going to see a much more severe presentation than what you see, for example, with hemosidrosis. Copper itself actually may result in free radical injury, when it starts to get deposited because of the lack of one of the enzymes that is entrusted in its excretion in the bile. The result of this accumulation is going to result in what is known as Wilson's disease, resulting from the accumulation of copper in multiple organs in the body. Now, ischemia-reperfusion injury. So what happened in this case? You are the good doctor. They wheel in to your ER a patient who has suffered from a coronary ischemia. This coronary ischemia resulting from an atherosclerotic plaque. So during the time period when this ischemia happened, and the patient presents to you, let's say it's about 20 minutes. During that time, actually, those cells in the area behind the ischemia have suffered actually injury, right? So some of those cells may not be able to make it. Why? Because they may have been experiencing ischemia over an extended period of time. Then an acute event happened in the form of a blockade. What's going to happen to those cells? They are going to die. So those cells will die and their membranes will open, right? And they will release their contents into the blood, into the nearby blood. What are their contents? Mainly the one that you worry about are the lysosomes, and you worry about also the calcium, especially the calcium. So now there is calcium that has accumulated in that area. Now there are other cells, including the cells that died. There are other cells that have been experiencing actually a reversible injury over that 20 minutes period. During this 20 minutes period, those cells that are experiencing reversible injury have their mitochondrial systems also break down. The results of that breakdown is that those cells are going to start to produce free radicals themselves because the mitochondria is no longer functioning. So those free radicals are going to end up actually in the blood. Let's say those cells die, open their contents, they will release their free radicals also in nearby blood. So now this blood that has accumulated behind the area of ischemia, after the blockade, if you will, have high contents of calcium, have high contents of free radicals. So you're the good doctor. The first thing that you're going to do is simply to go in and probe that blockade, right? Establish blood supply to the site. There's a couple of results that will result from your action. One of them is if the cell have been reversibly injured, but mildly, then everything will go back to normal, okay? Or actually the cells will have, what you have done will not really affect the outcome if a reversible injury happened, but there is no release of the contents. Or finally, the one that you would worry about the most is that the area of damage is going to extend beyond the original area of ischemia. And how does that happen? Once you actually reestablish blood supply to that site, you are really allowing the contents, that have accumulated behind the blockade to be released and to be exposed to cells that were not actually exposed to the blockade, the cells before the blockade. And the end result is going to be that those cells are going to suffer from the free radicals, are going to suffer from the increased calcium, and they are going to be damaged. So in this case, you will see that the damaged area will extend beyond the blockaded area. Is that clear? Let's take that as an indication that you got it. That is what is known as ischemia-reperfusion injury. Now, my question to you is how to avoid it. How to avoid it. Let's say, you want to make sure your patient does not develop ischemia-reperfusion injury. What do you do? Any idea? All right, let me tell you then, if you guys, don't want to participate, some of the choices that were picked by your colleagues used to be like, you give the patient a glutathione peroxidase, right? You give the patient some peroxide dismutase. You overload the patient with vitamin E and vitamin C. Do you think that works?
No.
Why not?
Because the excess amount of it will be excreted from the body anyway.
Right, and usually this is an instantaneous kind of injury, right? So probably the best way to ask you the question is how to prevent it from happening. How to prevent this from happening. And again, you actually giving the patient vitamin E and vitamin C and all the good stuff, all the glutathione, oxidase or the super dismutase will not really help him. In this case, the most important thing is to make sure that you wheel in the patient into the ER as soon as possible, because the shorter the period of injury, the less likely that those cells are going to die, and they are going to release the calcium, and they are going to develop the mitochondrial dysfunction and develop the free radicals. The shorter the time period, the more likely that this area behind the blockade will not develop, the high contents of calcium and free radicals and lysosomal, elements, and as a result of that, less likely for actually ischemia-reperfusion injury to happen. And that's, what we have talked about. Another actually element of why the injury happened. What happened when you have actually, injury to a tissue? One of the first things that will happen is that the inflammatory cells will be wheeled to the side. In this case, those inflammatory cells will be in two forms. One is neutrophils, and the other one is macrophages. Now, as a matter of policy, neutrophils and macrophages use free radicals in their functions. Okay, so when there is an ischemic area in the heart, macrophages and neutrophils will be brought to that side. And then when those actually cells in that area die, one of the cells that will die will be actually the macrophages and the neutrophils that are loaded with the free radicals, and that will also, chip in, that is going to contribute to the ischemia-reperfusion injury. Also, the fact actually that you have tissue injury that happens in those patients may actually also add the complement system, activation of the complement system to the whole process of ischemia-reperfusion injury. So it's multifaceted way to do it. The best way to prevent it is to make sure that this period from obstruction, from the ischemic event, the start of the ischemic event, to the probing of the blockaded artery is going to be as short as possible. When you do that, you will save your patient from this kind of injury. That's it. All right, any questions? Any questions here? You guys got it well. Sorry?
بالchat. What will be?
You will do the same thing. The only thing I'm telling you is to bring the patient as soon as possible to the ER. If you open a book, if you open Robbins, they will tell you that actually the myocardial injury will happen in 20 to 30 minutes. That's really, to me, that's not really true. It will happen in a much shorter period of time. One of the ways for that to happen is actually through this process. It will happen after you have done your intervention. So in order to avoid all of that, in order to avoid the death of the myocardial cells and to preserve the myocardium, in many different ways, really, it is to bring in the patient as soon as possible. What are the large densities in the mitochondria? Unknown. It is simply a morphologic kind of finding, really. I try to, to probe what it is. That's a good question. What is the contents? I believe it is, from the mitochondrial elements itself, but it does not really specify exactly what it is. Any other question? Cause calcium. What is that?
I don't know. It's most
All right.
important. That's it.
All right, thank you.
Give my- your USB.
All right.